This is Dung Nguyen, assistant professor here at the University of Kentucky. Today we're going to talk about cholinesterase inhibitors, neuromuscular reversal, and anticholinergic pharmacology. Just a little bit of introduction. Normal neuromuscular transmission depends on the binding of acetylcholine to nicotinic cholinergic receptors on the motor end plate. At these nicotinic receptors, non-depolarizing muscle relaxants compete with acetylcholine, thus blocking neuromuscular transmission. Muscle relaxation is achieved as neuromuscular transmission is interrupted. When this muscle relaxation needs to be reversed, cholinesterase inhibitors, aka anticholinesterases, are utilized. These anticholinesterases reversibly bind to the enzyme acetylcholinesterase, rendering it inactive. Anticholinesterases indirectly increase the amount of acetylcholine available to compete with the non-depolarizing agent, thereby reestablishing normal neuromuscular transmission. Commonly used cholinesterase inhibitors include neostigmine, physostigmine, pyridostigmine, and edrophonium. While the goal of neuromuscular blockade reversal is to increase the nicotinic cholinergic transmission, there's also a need to minimize the muscarinic side effects associated with the increased acetylcholine. This is where anticholinergics come into play. The side effects, however, of increased acetylcholine acting at these muscarinic receptors include, at the GI receptors, post-op nausea, vomiting, fecal incontinence, as well as increased peristalsis. At the cardiovascular receptors, you get bradycardia. At the pulmonary receptors, bronchospasm, as well as increased secretions. Therefore, during reversal of the neuromuscular blockade, an anticholinergic is co-administered with the anticholinesterase to minimize these unintended muscarinic effects. Commonly used anticholinergics include atropine and glycopyrrolate. Let's talk about specific cholinesterase inhibitors, and we'll start off with neostigmine. It is a quaternary ammonium that is lipid insoluble, making it unable to cross the blood-brain barrier. Maximum recommended dose is 0.08 milligrams per kilogram, up to a dose of 5 milligrams in adults. Effects are usually seen in 5 minutes and usually peaks at 10 minutes. These effects usually last more than 1 hour. The anticholinergic glycopyrrolate has a similar onset of action with neostigmine, usually dosed at 0.2 milligrams of glyco per 1 milligram of neostigmine. Therefore, these are frequently paired with one another. Neostigmine is also used to treat myasthenia gravis, paralytic ileus, and bladder atony. Physostigmine. It's a tertiary amine, making it lipid soluble and able to cross the blood-brain barrier. The ability to cross the blood-brain barrier limits its usefulness as a reversal agent for neuromuscular blockade. However, the ability to have an effect on the central nervous system allows it to be used in the treatment of central anticholinergic toxicity caused by overdoses of scopolamine or atropine. Dosing is 0.01 to 0.03 milligrams per kilogram. Physostigmine is metabolized almost completely by plasma esterases, unlike other anticholinesterases, which are renally excreted. Next cholinesterase inhibitor we'll talk about is edrophonium. It's a quaternary ammonium with a recommended dosing of 0.5 to 1 milligram per kilogram. It's less than 10% as potent as neostigmine. It's the most rapid onset of action, usually 1 to 2 minutes, and shortest time of effect of all the anticholinesterases in use. Due to its rapid onset of action, atropine is frequently co-administered with edrophonium since both have similar time of action. Although glycopyrrolate can be used with edrophonium, it should be given several minutes before edrophonium to avoid bradycardia. The last cholinesterase inhibitor we'll talk about is pyridostigmine. It's quaternary ammonium. Dosing is usually 0.25 milligrams per kilogram, and it's 20% as potent as neostigmine. However, its duration is slightly longer, about 2 hours. Glycopyrrolate is preferred over atropine as an anticholinergic paired up with pyridostigmine because its slower onset of action better matches that of pyridostigmine. Let's talk about organophosphates. Special class of anticholinesterases used in pesticides such as malathion, nerve agents such as sarin, and ophthalmic agents such as ecothiopate. These anticholinesterases irreversibly bind to cholinesterase, and exposure leads to increased acetylcholine. The poisoning with organophosphate leads to a cholinergic response of defecation, urination, meiosis, bronchospasm, bradycardia, emesis, lacrimation, and salivation. This can be easily remembered via the mnemonic dumbbells. Organophosphate poisoning can also present with muscle weakness, paralysis, seizures, and coma. Treatment for the organophosphate poisoning is prilidoxine to reactivate the cholinesterase enzyme, and then atropine, usually at the dose of 2 to 5 milligrams IV to counteract the cholinergic effects. We'll talk about anticholinergics now. There are 3 main anticholinergics that are used: atropine, glycopyrrolate, and scopolamine. These anticholinergics bind the acetylcholine receptor, effectively preventing receptor activation via competitive binding. And as mentioned previously, these anticholinergics are commonly administered prior to an anticholinesterase to lessen or prevent the muscarinic effects of the anticholinesterase. Binding of these anticholinergics to the acetylcholine receptor produces various effects depending on the organ or system involved. At the cardiovascular system, you get blockade of the muscarinic receptors, causing tachycardia. Respiratory, you get bronchodilation and decrease in airway secretions. GI, salivary secretions are decreased. Thermal regulation, sweat glands can be inhibited, leading to a fever, also known as atropine fever. Ophthalmic, you get cycloplegia, which is the inability to accommodate to near vision, and mydriasis, which are dilated pupils. Let's talk about specific anticholinergics. Atropine. Atropine is a tertiary immune. Dosing is 0.01 to 0.02 milligrams per kilogram IV or IM. Atropine has potent effects on the heart and bronchial tree, resulting in tachycardia and bronchodilation. It's the most efficacious anticholinergic for treating bradyarrhythmias. As such, it is seen in the ACLS algorithm for treating bradyarrhythmias. Even though it is a tertiary immune and can cross the blood-brain barrier, CNS effects are minimal after the usual recommended doses. Atropine should be used with caution in patients with narrow-angle glaucoma. Glycopyrrolate, quaternary amine. Dosing is 0.01 milligrams per kilogram, usually 0.2 to 0.3 milligrams in adults. Glycopyrrolate is a strong inhibitor of respiratory tract and salivary gland secretions, and this is one of the main reasons we use glycopyrrolate as a pre-medication to decrease airway secretions, especially in the setting of fiber optic intubations. Glycopyrrolate cannot cross the blood-brain barrier due to its property as a quaternary amine. Therefore, there are no CNS side effects. Glycopyrrolate has a longer duration of action, usually 2 to 4 hours, versus atropine, which usually lasts 30 minutes after an IV dose. As mentioned before, glycopyrrolate is usually paired up with the anticholinesterase neostigmine when muscle relaxation reversal is desired. Scopolamine. It's a tertiary amine. Dosing is 0.01 to 0.02 milligrams per kilogram, usually given in the IV IM dose. Causes significant CNS effects due to it being a tertiary amine, and these effects include amnesia, drowsiness, as well as delirium. Being a tertiary amine, the lipid solubility allows transdermal absorption, and this property is utilized in the setting of a scopolamine patch, which is highly effective in treating post-op nausea, vomiting. Scopolamine is also effective in preventing motion sickness. The last topic we'll talk about in the short discussion is central anticholinergic syndrome. This happens since atropine and scopolamine and tertiary amines, they cross the blood-brain barrier and cause CNS effects, which can manifest as a central anticholinergic syndrome. CNS effects include anxiety, agitation, confusion, disorientation, visual hallucinations, delirium, coma, and seizures. Systemic effects of central anticholinergic syndrome include dry mouth, flushing, fever, and dilated pupils. All these effects result from blockade of the cholinergic activity. Treatment of central anticholinergic syndrome is physostigmine, which, as mentioned before, is a lipid-soluble tertiary amine, allowing it to cross the blood-brain barrier and reverse the central anticholinergic activity brought on due to atropine and scopolamine. Dosing of physostigmine is 0.01 to 0.03 milligrams per kilogram. Here are my resources, and thank you for listening.